Good morning, everyone. So welcome to this session on non-communicable diseases, the challenges for people living with HIV. So my name is Kumarasamy, and I'm from Care Medical Center from Chennai, India. And my co-chair is Professor Judy Courier, who's from University of California, Los Angeles. She's a professor of medicine and chief of infectious diseases and the chair of AIDS Clinical Trials Group of USNH. As many of us as clinicians who are sitting in this room know very well that we come across this challenge of preventing and managing non-communicable diseases in our patients who live for many years with the currently available potent antiretroviral therapy. To talk about this, we have got 4 interesting speakers on a variety of topics, and each one will speak for 15 minutes, and we'll have a panel discussion at the end for 20 minutes. So hence, please hold your questions at the end of the session so that we'll have a panel discussions to discuss about all this. To initiate today's proceedings, first I'll turn over to my co-chair, Judy.
Thank you, Kumar. Thank you all for hanging in there for the last day. It's been great to see at this conference attention to non-communicable diseases and in different sessions, session on mental health earlier this week and others on cardiovascular disease. And today we're going to focus on a couple of different topics. And we also want to make sure that we know that people are going to be interested to go and hear former President Bill Clinton at 12:30, so we will end on time. So let's get started. Our first presenter is Dr. Janine Trevelyan, and Janine is an infectious disease physician and an HIV researcher. She completed her PhD and has been focused on the pathogenesis and prevention of heart disease in people living with HIV at the Monash University in Melbourne. She's currently on loan to UCLA, where she's a postdoctoral researcher. And her focus is also looking at biobehavioral strategies to treat and prevent cardiovascular disease and complications associated with HIV. And she's going to talk to us about metabolic disease in people living with HIV. Janine?
Thank you, Judy, and thank you to the organisers for the invitation. So I have no conflicts of interest to declare. And as Judy mentioned, there's been some fantastic sessions here at AIDS 2018 looking at non-communicable disease. I'm sure no one in this room needs any extra information about that people living with HIV are clearly at increased risk for non-communicable disease. And of particular focus to my talk, we now know there's robust evidence that people living with HIV are at increased risk for cardiovascular disease, as shown here with data from the North American cohort, the NA Accord, showing that at every age group, people living with HIV are at increased risk of acute myocardial infarction. And the pathogenesis of heart disease in people living with HIV is complex, with a number of traditional and HIV-specific factors, all interacting through a person's underlying genetics to determine whether or not they will go on to develop atherogenesis and cardiovascular risk. And so as the start to this session, I've been asked to talk briefly about one of the areas that can both lead to direct morbidity but also does increase the risk of cardiovascular disease, and that we probably haven't heard that much about yet in this conference, and that's metabolic diseases. And in particular, I'm going to focus on the 2 interrelated conditions of obesity and type 2 diabetes, looking at both the HIV and antiretroviral associations with severity, incidence, and a little bit on the screening and prevention. And obviously that means that there are a number of really important metabolic conditions I'm not going to be able to talk about given the time constraints this morning, some of which you can see on the figure behind me, and that should not be taken to mean that they're of any less importance. And so it takes a little bit of a frame shift, I think, to be standing at a HIV conference and thinking about obesity. For such a long time, we've thought about and worried about conditions like malnutrition and wasting and cachexia, and in some centres and in some individuals, that's still of very importance. But actually, obesity is now common and becoming more so in people living with HIV. And this is not just a problem in people in well-resourced settings. In fact, 27% of people living with HIV in low and middle income countries are already overweight or obese in sort of recently published data. And when I'm talking about overweight and obese, during this talk and in general in the publications, you'll see what we're talking about really are the categories that have been set aside based on body mass index, which is a person's weight in kilograms divided by their height in metre squares, and sort of fairly well-defined thresholds from underweight to very obese. And there are some issues with using BMI. For instance, obviously it doesn't take into account the difference between muscle mass and adipocytes, but it's a reasonable sort of marker to use as we're moving forward. And so the first thing to sort of step back from and say, and we've known for a long time, is that weight gain is very common with initiation of antiretroviral therapy. And on average, an individual who starts ART will gain around 2.5 kilos or 5 pounds in the first year post-ART initiation. And in people who are of low weight or low normal body weight before they start antiretroviral therapy, that increase in weight gain is actually associated with a decrease in mortality and morbidity. And hence, for a long time, we've sort of thought about this weight gain as being a kind of return to health sort of phenomenon, that this is just removing the negative metabolic effects of HIV, or some of them, and letting people come back up to the population norm. But actually, what I think we've all suspected, and what was shown, quite nicely just from the DAD group in the last few months, is that there is this J-shaped relationship between body weight and poor outcomes in people living with HIV. What do we mean by that? We mean that, yes, of course, people who are very underweight are at increased risk for overall all-cause mortality, and a lot of that will be associated with, as we've talked about before, malnutrition, poor immune compromise. But that also at the other end, in people who are overweight or obese, there's an increase in the risk of cardiovascular disease, for non-AIDS related cancers, and then particularly, as you can see here, for diabetes. And actually the weight gain that people are experiencing when they are also HIV positive is probably associated with a higher risk for diabetes and cardiovascular disease than what we see in the general population. So for instance, we can see that in both this study with both HIV negative and HIV positive participants, that there is this nice, or this consistent linear association between weight gain and the hazard ratio for developing diabetes. But you can see that that slope is much steeper in the people living with HIV. In fact, for every 5 pounds of weight gain, or every 2.2 kilograms, people living with HIV experience a 14% increased risk for diabetes compared to only 8% in HIV negative. And a similar relationship is seen with cardiovascular disease and some of the other complications of obesity and weight gain. We're also learning that the location of the fat and the type of the fat is also important. So I think many people are probably aware of this concept of a difference between subcutaneous fat and deep visceral fat, which is sort of more associated with some of these bad metabolic outcomes that I've been mentioning. But we're also now learning about the differences between brown and white adipose tissue. Brown adipose tissue, sometimes called good fat, contains a number of mitochondria, it generates heat, it's often found in the neck and chest and upper back, compared with white adipose tissue, which is really for large storage of lipid globules, has a stronger effect on endocrine abnormalities. And although this is an area that's just beginning to really be understood in people living with HIV, there is some early work that suggests that there may be dysfunctional fat in the setting of HIV and in the setting of a normal BMI, meaning that the adipose tissue is more inflamed, perhaps leading to more endocrine abnormalities. And that's really an area of ongoing investigation I think we're going to learn more about in the next few years. And what are the reasons for weight gain? I think it's really easy when we start talking about obesity and people being overweight to just sort of blame all of that on poor diet choices, poor lifestyle choices. Just as an aside, this is a picture of a triple bypass burger, it's called. It's from a chain, you can probably imagine which country we're from, called the Heart Attack Grill. Ironically enough, actually, the spokesperson for the Heart Attack Grill, their motto is that it's a taste to die for, and their spokesperson did just that outside one of their stores from heart disease, given that he had lunch there every day. But I digress. Anyway, the point I was making was that actually, while obviously what we eat and how access to quality food and quality nutrition is important, it's not the whole story, particularly not in people living with HIV. And there's good evidence to show that actually people's diets don't necessarily change that much when they're starting antiretroviral therapy, but that weight gain is consistent. And so why are they gaining weight? Well, some of the factors associated with weight gain in people living with HIV, increasing age, a lower high school education, people from uninsured minority backgrounds, female sex, so women are tending to gain more weight than men, and as I've said, antiretroviral therapy in general. But we've also in recent years learnt that it's not just antiretroviral therapy and that some drug classes are probably more related than others. And so there's been this signal just in the last year or two that perhaps integrase inhibitors are causing more problems than we first thought. So this data from the French group, this retrospective analysis, was triggered when they were going back to have a look at why people were stopping their integrase inhibitors. And they found that 7% of people reported that they wanted to stop their integrase inhibitor because of weight gain. And they were a bit surprised by that, so they went back and had a look at what was the average weight gain in this group of largely middle-aged, well-controlled individuals, most who had a normal BMI at baseline, who were either starting antiretroviral therapy or swapping onto antiretroviral therapy. The vast majority, 92%, who were swapping. And what they found was that in general, most patients who swapped onto a dolutegravir-based regimen in this instance were gaining weight. And that was particularly prominent in the women who were gaining on average 4 kilos. The more concerning thing is that a fifth of patients were gaining more than 10% body weight, and that's really a significant amount, both for the individual and thinking about the cardiac complications of that, or consequences. And this work's been supported by now 2 other groups and some other work that's ongoing. So on the right, you can see some data from the ACTG, which again showing a greater increase in the number of individuals who had severe weight increases with starting a integrase-based regimen, in this instance raltegravir. And it does seem that this is a class effect. It seems that with all of the integrase inhibitors there's some degree of weight gain, but that the effect probably is greater with dolutegravir. And work's ongoing at the moment trying to figure out exactly why that's happening. And why does this matter? Why does obesity matter? And it matters, as I've said, because there's ongoing metabolic complications, and I think particularly because of the strong link between obesity and type 2 diabetes. And I just wanted to step back for a second from this HIV-specific focus and just talk about the context that this diabetic incidence is happening in. So the International Diabetes Federation has predicted that in the next 30 years, the number of people living with diabetes in the world will cross over 600 million. And that increased risk is really going to be carried by countries in Africa and Southeast Asia, which are going to see huge increases. And obviously that's going to have a significant load on centres that are already dealing with a number of communicable and other diseases. In fact, 4 out of 5 people living with diabetes are already in low and middle income countries. And as I said, that's projected to increase. So that's really going to be quite important with these overlap between the HIV and the diabetic epidemics. Of reassurance, in some ways, this data from the Danish cohort showed that there was no difference, though, in the incidence of diabetes between people living with and without HIV. And that data is, I think, really supported by a number of studies that have looked at the prevalence of diabetes in people with HIV, just a few of which I've summarised for you here. So you can see North American studies in green, European studies in blue, Asian studies in red, and African studies in this kind of goldy yellowy colour. And I think there's a couple of things to point out and take away. One is this real variance in the prevalence that's being reported, and some of that can probably be explained by the number of the types of ways that they're determining diabetes. Obviously, this is only people who are being diagnosed. There's a number of different variables that can explain that, some of which probably is a difference in incidence in different countries. And then the other thing to look at is that, on the right-hand side of that graph, there's the International Diabetes Federation prevalences in those individual areas. So you can see that most of these studies are falling below the numbers that are sort of being estimated for the area. So probably it is true that diabetes is not necessarily increased in people living with HIV. I want to draw your attention to that little asterisk over here, and we've got these two studies by Todd Brown, older studies in 2005. This is actually the one study, and this is people living on antiretroviral therapy and not. And that really is the exception to this concept that diabetes is not increased with people living with HIV, in that it clearly is increased in people who are on some particular antiretroviral therapies. Now, mostly that's older agents that aren't as used as commonly, but as you can see in this South African study, it's also seen with efavirenz, which a number of individuals are still on. And while the magnitude of that increased risk is small, taken over a lifetime of exposure to antiretroviral therapy, obviously that can have a significant impact on the incidence of diabetes. But in general, the risk factors for developing diabetes in someone with HIV are really the same as those in the general community. So it's being more than 45 years old, not being very active, particularly having a family history of diabetes, or having high blood pressure, gestational diabetes, or, as I've mentioned, being overweight. The one sort of proviso to that is that there is this association between hepatitis C infection that may be slightly higher in people living with HIV, a slightly stronger association. There's about a 4-time increased risk of diabetes in people who are also hepatitis C positive. And so what does that matter? Well, it matters because even though I've said that perhaps the incidence of diabetes in people living with HIV is no greater, the overall prevalence, given that what I've said that in the general community it's increasing so much, means that for people looking after people with HIV and people living with HIV, we're all going to need to be much more aware of the consequences. And particularly the question is raised, are the micro and macrovascular consequences of diabetes greater in people living with HIV? In a clinic in sub-Saharan Africa, they looked at the prevalence of retinopathy and proliferative retinopathy, which leads into blindness, and actually found that participants with HIV were not at increased risk compared to the general population. So that's a good start. However, with kidney failure, we can see that there is a clear additive effect with participants who had both diabetes and HIV having an almost doubling of the risk of having either alone. So that's again going to be a big problem moving forward for us. So what can be done? Obviously, you can't prevent a complication, you can't prevent an illness if you don't know that it's there. So the most important thing is to screen. And it really can be fairly simple, using just a simple fasting blood sugar for diabetes, obviously just thinking about it and weighing your patients. And while there are issues with, I've said, with all of these measures, and there's new and fancier ways to diagnose things, actually if we were able to just do this for all of the people living with HIV, that would make a big difference. I just wanted to put a very side comment just about HbA1c, obviously widely used now for diagnosis of diabetes, but it can slightly underestimate glycemia in people living with HIV. So you can see that slightly yellow, the yellow line, a little bit lower than the blue line there. And so just again, something to keep in mind if you're using HbA1c and you're getting a borderline one. The other thing to say is that in people living with HIV, lifestyle interventions work. I don't have time to go through them all now, but I just want to highlight that for you. There's lots of studies, lots of different means of trying to reduce weight, reduce diabetes, diet, exercise programs, and they all do work. So in conclusion, weight gain post-antiretroviral therapy, I think, is not simply a return to health phenomena. We need to kind of change our thinking around that. And the metabolic diseases that are following on from a weight gain can lead to significant morbidity burden in people living with HIV. We need to think about screening and interventions to prevent them and reduce them moving forward. So I just wanted to thank the multitude of participants who've contributed to all this data that I've so grossly summarised here today, and to thank all my collaborators at Monash and at the Care Centre at UCLA.
Thank you very much, Janine. That was outstanding. Now we're going to move to non-AIDS cancers, and I'm pleased to introduce our next speaker, Jean-Philippe Spano, who's a professor of medical oncology in the Department of Medical Oncology at the Pitié-Salpêtrière Hospital in Paris. He's completed medical oncology training and did a PhD on KS and predictors of progression, and also spent some time at the MD Anderson, and he's kept one foot in the HIV cancer world while pursuing a career in medical oncology. So he's really well positioned to talk to us about non-AIDS cancers.
Thank you, Jody. Ladies and gentlemen, good morning. Yes, I'm very glad and a great honor for me, and thanks to the scientific committee to present it to you today, an overview concerning the non-AIDS cancers in patients living with HIV. Obviously, there is an elevated risk nowadays for many cancers in people living with HIV, maybe due to the long survival, to the long immunosuppression. And as you know, people living with HIV is aging. But before art, I've noticed already that there were a higher relative risk for developing so many cancers compared with the general population, and especially for cancers associated to oncogenic virus. And for instance, EBV for Hodgkin disease, or HBC or HCV for liver cancer, or HPV for anal and cervix carcinoma. But also we knew that before art, there is an elevated risk for lung carcinoma. Nowadays, I invite you to read this recent overview published in the New England Journal of Medicine that have related the different kind of non-cancers in the United States, but it's the same all over the world. And the four main cancers are nowadays lung cancer, anal cancer, Hodgkin, and hepatocarcinoma. And when you look at the evolution of the risk of the most common non-AIDS cancer during the art period, you can see that by now there is a decrease in incidence of lung carcinoma. And I would like to thank the work of Domenico Staghiola, the head of my department of INSERM, because our department have demonstrated that there is a decline, maybe due to the smoking prevention, but also due to the improved immunocontrol, and also, as it was demonstrated in the US, the decrease in incidence of recurrent pneumonia and tuberculosis. As for Hodgkin disease, depending on the studies, there is a declining or no change in incidence. And as for the liver, in France, and especially also in Europe, the incidence is increasing, except in US, as it was published recently in Lancet HIV, maybe due to the still long-term exposure to the HCV and the high prevalence in HIV population. And as for anal canal, there is an issue now, as you know, for preneoplastic and also anal cancer. And we can say that now there is a trend of diminishing incidence or no change according to the studies. But as you can see, even though the incidence is increasing for this main non-AIDS cancers, there is still an elevated risk, emphasizes the fact that we have to go on with screening and prevention program, because as you can see, the relative risk remains higher compared with the healthy people, especially for lung, Hodgkin disease, liver, and anal. And you can see that compared with US and Europe, the relative risk for HIV people for anal cancer can reach more than 70. What about the risk concerning the different clinical or biological characteristics of this kind of population? For instance, for the patient who have more than 500 CD4 count, I remind you two main studies. The first was published with my INSERM team, with Domenico Staghiola, and published in Lancet in 2009. And we have demonstrated that when a patient is very well controlled, but that means that the CD4 are more than 500, more than 2 years of treatment, you can decrease significantly the risk of developing some non-AIDS cancers, and especially for lung, that can reach the same relative risk that than the population, the general population. In the Kaiser Permanent, the Silverberg study, it was the same, but not really the same striking of the relative risk, because the patients were not treated more than 2 years with a CD4 count more than 500. Concerning smoking, there is a special presentation concerning lung disease in our session today, but I would like to emphasize that, of course, smoking is a very, very important risk in such population, and several studies have suggested that the risk of lung cancer was higher among HIV people, regardless of being a smoker. But recently, also a Danish study has demonstrated that finally higher risk of cancer among people living with HIV are smoking-related cancers, but also virus-associated cancer. And in non-smokers, only the risk of cancers associated with viruses is high. I would like also to emphasize that for lung cancer, chronic pulmonary inflammation or abnormal immune activation and repeated lung infections can also be a risk factor for developing such a cancer. Do cancers occur at younger age among HIV people? Yes, because there were some studies published in the literature that finally have shown that HIV can accelerate the cancerogenesis process. In fact, we have to remind you that the age distribution is different compared to the general population, because the median age is between 50 and 16, even though we know that people living with HIV is aging. And we can notice finally that people living with HIV can present some lung, liver or anal cancer at younger age than the healthy population. But nowadays, the other issue is that you know that the only risk factor for cancer is age. Is aging. And people living with HIV, fortunately, is aging and growing in size. So caution must be paid for the most common cancers in the general population. I mean breast, colon, and prostate. That means that we have to go on with the screening and prevention program, especially, for example, with food, as my colleague Janet has just mentioned to you a little while. Concerning the survival, we have improved. We have improved the survival of patients living with HIV with cancer for many years. Why? Because on account of the screening program, on account of the more immune control, on account of the fact that people living with HIV with cancer can be and must be treated as the general population. And for instance, to improve or to optimize for patients living with HIV with cancer, their care and cure, and to be treated as the general population. In France, we have created 4 years ago a multidisciplinary board with some web conference where every cases of cancer can be presented to this multidisciplinary board, a board that include specialists in HIV, oncologists, immunologists, pharmacologists, and by now, more than 500 people were presented. And what we can see is that the lung cancer is the most common cancer now in France, and the number of cases is impressed. But also you can see that you can have anal cancer, but also head and neck and breast. And Roman Panish had presented to you 2 days before, during this meeting, the cases of Kaposi's sarcoma in immunocontrolled. And this is also the goal of our multidisciplinary board, is also to have some epidemiologic data. And now, as I said, concerning the main non-AIDS, the most important and the most frequent are the lung, anal, head and neck, and breast, and colorectal cancer. That was not at this time considered as frequent in the population, in the general population. But I would like to also point out the fact that in Africa, for instance, breast cancer is increasing, and especially in people living with HIV, and remain for me a new issue. What is the goal? What is the goal of our multidisciplinary board? The goal of our multidisciplinary board is to optimize and to provide to people living with HIV the same treatment than the general population. And for instance, we can propose some oncologic treatment and make sure that the treatment that was presented or that was proposed to the patient is good. But also we can propose, of course, a modification of the antiretroviral treatment, as you know, on account of the drug-drug interactions. As you can see, and as you know, one of the gold standards in oncology now remains immunotherapy. Immunotherapy that is now a gold standard for many cancers such as head and neck, kidney, lung, and so on. And we also know that HIV can provide or provoke an increasing of the expression of some immune checkpoint receptor like PD-1 and can promote the progression of the disease for HIV and cancer. So there is an issue. Yes, there was an issue how to use immunotherapy in people living with HIV with cancer. So we have decided to look at and to monitor strictly this kind of patient. And for instance, in our multidisciplinary board that was proposed 35 positive reviews for immunotherapy because we have really made information that people living with HIV must be treated as the general population. And by now, more than 20 patients receive immunotherapy treatment. And as you can see, because we have some publication indeed, and you can see that immunotherapy is well tolerated by now concerning clinical aspect and biological aspects. But we have decided to launch a very PD-1 national program that include some specific clinical trials, because you know that people living with HIV, with cancer, are generally excluded from clinical trials in the oncology. So we have really worked and hardly worked to permit and to allow pharmaceutical industry also to launch some clinical trials specifically in people living with HIV. And we have succeeded, for instance, with lung, and now we've got a clinical trial, ongoing clinical trial with levolumab. Levolumab is an anti-PD-1 as immunotherapy aspect and treatment for lung. And also with the head of ANRS and Jean-François Delfrécy, we have launched a cohort. This cohort is just to monitor people living with HIV with cancer that will receive some immunotherapy, and in the goal to get some information, clinical and biological information. So in conclusion, well, I would like to emphasize the fact that oncologists, hematologists, pharmacologists, and you were dedicated to HIV patients and also specialists in HIV have to work all together because, as you know, cancer has become a very important cause of morbidity and mortality in people living with HIV, and we have to go on, especially in screening and prevention program, and help people living with HIV to get the same treatment and the same chance for the treatment when they face also an cancer, and invite you to our website, cancervid.org, that can help you because, for instance, we have written information booklet for patients that were very appreciated in France, in the different associations in France, to help patients for the best concern care and hopefully cure. Thank you.
Thank you for the excellent talk. So let us move to the next topic. This is on the lung disease and smoking. So this is going to be by Dr. Ken Kunisaki, who is from the University of Minnesota. He's a respiratory physician and he's an associate professor at University of Minnesota. He's been widely known across the globe on various pulmonary studies in HIV-infected people. He also leads the pulmonary sub-study of the START study and several pulmonary studies in the U.S., mainly in the MAX and WISE. Ken.
Great. Thank you very much. Well, it's an honor to be here today to speak about lung diseases and smoking. I put smoking in quotes for reasons I think you'll see in just a bit. These are my disclosures. So I have three goals with today's talk. Number one, I want to talk about emerging data regarding lung disease in patients living with HIV, with a specific focus on lung disease in low to middle income settings. and then talk about the role of smoking in environmental exposures as well, something I think we aren't talking enough about. So when we think about the lung and HIV, this is where it all started, right? So pneumocystis, the recognition of pneumocystis, patients who are presenting with an unexplained cystic lung disease with pneumothoraces, led to the discovery of HIV and AIDS. And over time, with combination therapy, I think very thankfully we don't see this clinical entity as much anymore. And as we've come into this combination therapy, that we've really gone away from infectious complications towards non-infectious complications. Although I'll still say that bacterial pneumonia remains problematic, that even patients on effective combination antiretrovirals appear to have a higher risk of bacterial pneumonia. And this is not meant to go through these sort of data, but I'll just highlight there is ongoing work in this area. In particular, Paul Collini and his colleagues in Sheffield, England, recently published this article in one of our leading respiratory journals, a really elegant set of experiments trying to look at mechanisms for why bacterial pneumonia remains problematic, even in the face of effective ART. So I'm going to talk here today about non-communicable diseases of the lung. You've already heard a little bit about lung cancer. I think a lot of people have heard about pulmonary hypertension as well, which I'm not going to touch on today, mostly because even though it may still be problematic in patients with HIV, it's relatively uncommon. And I'm going to focus on COPD, or chronic obstructive pulmonary disease, which is the most common clinical entity that I think you'll be running across. So just a quick primer on COPD for those less familiar with the disease. So this is a sort of a depiction of what's happening in the lung. This is a normal lung. At the top there, you see a normal airway that's attached to alveoli. The alveoli and the lung structure provides that airway some additional support. And with a normal lung, you should be able to exhale very quickly, forcefully. And orange there is you can reach a high peak flow. And at the end of a forced exhalation, only about 25% of the air in your lung remains. You can exhale about 75% of all the air in your lung. Contrast this normal lung to a lung with COPD. So in the cartoon here, you can see that the alveolar attachments are broken. This is what you see as emphysema, and so there's less support for that airway. So that leads to an airway that's collapsible. There's also inflammation and there's fibrosis in the airways as well. All these things lead to a smaller airway diameter. So the caliber of that airway lumen is smaller, which leads to airflow obstruction. And in orange there, you can't generate as much peak flow, and most importantly, you see that in the purple there at the bottom, that residual volume. You can't exhale all that air out of your lungs, and so you have air trapping, which leads to the symptom of shortness of breath. So that's what COPD is from a physiology standpoint. From a public health standpoint, these are global burden of disease study data published in Lancet in 2012. Well, they found that in 2010, they estimated COPD to be the third leading cause of death in the world. Now, I think there's different methodologies here depending on, there's been different iterations of this, so in every country has different data. You can go to the website and actually look at your own country's specific data, but suffice it to say that COPD is certainly one of the leading causes of death in the world. And I think particularly in this session, you'll see that lung cancer is there and HIV is there. So I think what we're talking about today really has a lot of global health impact. And thinking of in terms of the lung, the other things in blue, the other non-communicable diseases in blue here, we hear a lot about heart disease, diabetes we just heard about, cirrhosis, liver disease, cancers, kidney disease, but we haven't heard a lot about the lung. And so I'm really glad to be here today to talk about this a little bit more. So in terms of what is the prevalence of COPD in patients living with HIV, so Jean Bignan and colleagues recently published this really nice meta-analysis in Lancet Global Health, looking at what is available in the literature. And this is sort of a depiction of this is the prevalence estimates. And on the top there, these are top versus the bottom. These are different definitions of COPD. The COPD does require lung function testing to confirm the diagnosis, but nowadays this can be done with simple handheld portable spirometers in the office setting. And no matter which definition of COPD they looked at, the prevalence of COPD was about 10.5%. So 1 in every 10 patients in these publications had evidence of COPD. Now, normally at this point in a lecture, you would say, oh, most of this data comes from high-income settings, but actually these studies in orange here highlighted actually came from low to middle-income countries. And then in one of the other studies here, our START pulmonary sub-study of nearly 1,000 participants, actually 60% of them came from low to middle income countries. So this is actually a disease for which we have actually a fair amount of data from low to middle income countries. And when in this meta-analysis, when they looked at this by income of the countries, you can see that it did look like there was a bit of a difference, that the prevalence was higher in high-income countries compared to upper and lower to middle-income countries. And part of this may be related to things like smoking prevalence, but I'll point out that using this lower limit of normal definition, you would expect something around a 5% prevalence of disease by this particular definition. And you can see that even that confidence interval excludes a 5%. And so it looks like, and there's other studies as well, suggesting that HIV remains an independent predictor of COPD. So why is COPD prevalence high in HIV? Well, I don't know that I have the answers per se, but there's a lot of different work out there looking at things like monocyte macrophage activation, secretion of pro-inflammatory cytokines that may play some role, things like impairments in glycolysis leading to mitochondrial toxicities, apoptosis, and oxidative stress. If you think that oxidative stress is important in HIV, keep in mind that the lung has the highest oxygen tension of any organ in the body, and therefore the lung is particularly prone to oxidative stress. We hear a lot in these meetings about the microbiome, particularly the gut microbiome, the vaginal microbiome, but please keep in mind that the lung has a microbiome as well, and there are ongoing studies to look at the lung microbiome in patients living with HIV. Like some of the other end organ diseases like cardiovascular disease, bone, or kidney disease, there have been interest in whether some of the ARVs themselves may be potentially harmful to the lung. We have an opportunity to look at this within the START trial of immediate versus deferred ART initiation, where we are able to nest in a pulmonary sub-study in about 1,000 of these participants. We measured lung function at baseline and every year throughout follow-up. And we actually found no difference in the rate of lung function decline between immediate versus deferred ART initiation. And so I think our data suggests that earlier ART does not seem likely to reduce lung disease or COPD in HIV. And lastly, I think what many in the room are probably thinking about would be smoking. And so in terms of smoking and COPD, so when we think about COPD, we say far and away the largest risk factor for development and progression of COPD is cigarette smoking. And that accounts for about 80% of COPD. But then there's still this 20% of COPD that isn't explained by cigarette smoking and can occur in non-smokers. So what is this non-cigarette COPD? Well, there are many things out there, I think, particularly relevant to patients with HIV. For example, things like air pollution. So whether that's in India or in China, you may have seen these pictures from the Beijing Marathon in 2014. I can't imagine running 26 miles with a mask over my face, but that's the point at which it can get in some of these large areas. These are data looking at, actually using satellite data to estimate air pollution levels. So this is 2005 in a snapshot of Asia. You can see in particular in dark areas of China in particular have very high levels of air pollution. By 2011, if you focus on China, things had actually gotten a little bit worse, particularly in the west and the southeast. Also can see what was happening in India. And then in 2015, if you focus in on China, I actually see that things actually got a little bit better, both in the western regions and in the western region and southeastern regions. And then you can see what happened in India, where air pollution levels continue to rise to the point where these days New Delhi is often quoted as having some of the worst air quality in the world. So there's outdoor air pollution. Other causes of non-cigarette related COPD include things like indoor air pollution, so using biomass fuels for heating and cooking inside the home. That may be a particular risk factor for women who tend to have higher exposures, and also children who may have impaired lung development because of growing up in these homes and being constantly exposed to biomass smoke. There's also things like tuberculosis. So tuberculosis is actually a risk factor for developing chronic airflow obstruction and COPD. And lastly, socioeconomic status. So there's data out there about that low socioeconomic status is also associated with COPD. I think it's no surprise to people in this room that low socioeconomic status also correlate with some of these other things, including tuberculosis, biomass smoke exposure, and even outdoor air pollution, that there's data about living closer to a highway, for example, increases the risk of COPD, and that tends to be associated with lower socioeconomic status as well. So HIV, among patients living with HIV, COPD is common. I think it's probably multifactorial, that like a lot of diseases, there's a lot of different pathways that lead to this disease that I touched on here: immune dysfunction, inflammation. There's studies about viral persistence in the lung as a reservoir, infections and microbiota, and then smoking. And I put smoking in quotes again, cigarette smoking, but also air pollution, both outdoor and indoor. So what's the road future? What can we do to reduce lung disease and HIV? And clearly, cigarette smoking is very important. And this is not important just for the lung. It's important for the heart. It's important for cancer prevention. And so I'm not going to spend a lot of time talking specifics about smoking cessation interventions, but suffice it to say there are data out there about how we can begin to tackle this. Other thing is outdoor air pollution. So I touched a little bit on what happened in China in terms of they have actually made some progress in reducing air pollution levels. Same thing has happened in the United States. Now, reducing outdoor air pollution requires a lot of political will and ongoing political will, but it can be done. It just takes a lot of work, but it can be done. Indoor air pollution. So there's been a lot of interest and promise regarding clean cook stoves. So these are stoves that still may be using biomass, things like either pellets or wood, but burn a lot cleaner to reduce the levels of air pollution inside the home. I have to say that the promise of clean cook stoves has been somewhat disappointing in the early outcomes for things like childhood pneumonia incidents, things of that sort. I think the story's not over quite yet, but for example, things like COPD, they take decades to develop, and so a lot of times in the short span you can do an intervention. Sometimes it may be difficult to know if that's making an impact on things like COPD or heart disease or cancer. So clean cook stoves is one approach. The other approach is things like electrification and using solar power. There are studies ongoing in those arenas as well. And lastly, I think just we need more science, that we really need more science to understand the impact of HIV and changes in, for example, things like the microbiome, things in inflammation, oxidative stress, epigenetic modifications, that we just need to tackle this a little bit more and a little more science. A lot more science, actually, will be needed in order to address this long term. So with that, I will close and end. I just want to thank all my collaborators that have been helpful in this regard in terms of collecting data about lung function and HIV, and thank the participants in not only our studies, but multiple other studies who have contributed to our knowledge about lung disease and HIV and to our funding institutions. So thank you very much.
Thank you, Ken, for this outstanding review. Please keep your questions for the panel discussion. The next topic is on non-communicable diseases in research-limited settings. This is going to be done by Professor Gerald Younger. So he's a cardiologist and a physician from University of Nairobi in Kenya, who have done outstanding work in the field of non-communicable diseases in research-limited settings and widely published. He's also the chair of the East African Non-Communicable Disease Alliance, and he is going to talk to us on non-communicable diseases in research-limited settings. Dr. Younger.
Thank you. Thank you for the invitation to make a presentation in this particular session. We've heard about metabolic disease, cancer, and lung disease. So I'll concentrate a little more on health system issues related to non-communicable diseases and people living with HIV. So I have no conflict of interest, except that I've been working with the NIH Fogarty on an NCD HIV integration project, which we finished recently and had a session on Monday and presented quite a number of papers there. And we have a supplement of AIDS Journal, which I would invite you to actually read. It's very interesting reading on the health system issues related to HIV and NCD integration. So I'll concentrate on 3 topics mainly: rising burden of NCD, which you've already heard, and the NCD-HIV interactions at health system level, and then some of the interventions that we think we should be getting involved in. So we all know now that NCD is a major killer globally, accounting for 71% of deaths globally, and also that most of these deaths, unfortunately, occur in low and middle income countries, which unfortunately also suffer the highest burden of HIV infection. And the 4 main conditions which we've addressed today are actually responsible for most of the NCD deaths, and unfortunately also are increasingly becoming important causes of morbidity and mortality in HIV, namely cardiovascular or cardiometabolic disease, cancers, and respiratory diseases. So if you look at the change that has occurred in the last 10 years or so in the mortality due to NCDs, unfortunately the highest rate of increase in mortality from NCDs is in sub-Saharan Africa, where the burden of HIV is also fairly high, causing what we call the double burden, or some people refer to it as triple burden of disease in this particular region. So this is a graph from the Republic of Kenya Ministry of Health sector plan, which projects that if we do nothing about NCDs in the next 15 years or so, or actually 12 years or so, then by 2025, there'll be an intersection whereby NCDs will become the major cause of mortality in that particular country, even overtaking HIV. So hence the importance of having a health sector plan that includes all diseases instead of silo programs for universal health coverage. So the main causes, apart from death, the disability-adjusted life years lost. Also, you can see the projections is that by 2030, the biggest problem, if you can look at, I don't know if you have a pointer somewhere, if you can look at the section on non-communicable diseases, number 4, you'll see that by 2030, that's the biggest change in mortality projected by 2030. And therefore, the need for us to pay attention on this. People living with HIV are the ones who are at increased risk of NCDs from most of the data that has been presented before me and many others that exist in literature. And there are many causes, as has already been mentioned, so I'll not repeat that. And I think this is something which you've already seen. And there's the changing face of cardiovascular disease and indeed many other NCDs in HIV, especially in the era of highly active antiretroviral therapy. These are just some evidences from some of my students on the latent features of non-communicable diseases amongst people living with NCDs. So peripheral artery disease, metabolic syndrome, which has already been mentioned, and the fact that before the huge rollout of highly active antiretroviral treatment, the major causes of cardiovascular disease were mainly related to the effects on of infections and the effects, for example, in the myocardium, on the functions of the myocardium, and not the metabolic causes, as we're beginning to see. So there's been an interaction between the traditional risk factors, the longevity of the disease, and the antiretroviral treatment that we give, and perhaps, I say perhaps, the lack of concentration on control of the traditional behavioral risk factors among people living with HIV, assuming that perhaps that's not one of the causes of morbidity and mortality. So there are 3 kinds of patients we do see when we talk about HIV and CVD. There are CVD patients who develop HIV, originally having myocardial infarction or valvular heart disease, or indeed hypertension, and then they develop HIV. And then there are patients who have HIV who, in the course of time, develop CVD. And then we have people who, at incident diagnosis, have both of them. The question you ask yourself is, does it matter how this happens? The answer is yes, not because of any pathophysiology as such, but because of the way people enter into the healthcare system and the way they are treated and that actually, unfortunately, determines outcome. If you have a CVD and you develop HIV, you will have to attend both CVD and HIV clinics separately in most setups in low and middle income countries at the moment. And many times there are no organized CVD care in those countries. If you develop HIV, if you have HIV and you develop CVD, you will receive good HIV care, but you will also now need to start going for CVD care. And if you're diagnosed with both, then again, there's that confusion of where do I start and where do I go. So silos do cause problems and do affect outcomes in these groups of patients. So integration is an important subject, and that's what we dealt with in most of the studies that I've done so far. And we do know that now there is ample evidence of feasibility, more data is needed for acceptability, and certainly much more in sustainability, especially if you consider the healthcare system innovations that need to be done to be able to accommodate both in a sustainable and scalable way. So there's need for research addressing the best ways of scaling up NCD prevention and care programs, especially in HIV, high HIV burden areas in low and middle income countries. So there are common challenges between these two diseases, which also lend themselves to each other. And indeed, there could be synergy. And some of the remaining challenges in HIV control programs, perhaps their solutions or some of the way forwards lie in integration, especially things to do with stigma and things to do with sustainability in low and middle income countries, where with reducing funding from donors, one needs to find for innovative ways for healthcare financing and sustainability of the healthcare system. So leveraging lessons from HIV is also important. HIV has become a chronic disease and indeed becoming a model of a chronic care program, which lends itself well to care of NCDs as well. So right from screening, behavior change communication, which can be integrated apart from behavior change communication for reducing risky sexual behavior, they can also be moved to diet, appropriate diet, physical activity, reduction of alcohol control, and cessation of tobacco, as has been mentioned by my previous speakers, which you will agree with me, all those will not only benefit NCDs, but will also benefit the welfare of a patient living with HIV. So silos in healthcare system in Africa is a big problem. We have systems for reproductive health, and some of the major causes of reproductive health, morbidity, and mortality are actually NCDs. And we have TB, and the TB interaction with diabetes is well known to most of you, and HIV and CVD is well known to most of you. So it's important that these silos are gotten rid of. So this is a slide of one of the projects that we're doing in the field, where we're involving the community health volunteers and extension workers and peer counselors to integrate behavior change communication for NCDs into HIV program at community level, so that they can be able to deal with the same diseases with the same resources in a cost-effective manner. And point-of-care diagnostics, as exists for HIV, also exist for cardiometabolic disease, which can be used. And protocols, healthcare care pathways can be done to integrate the two. And there are research models, again, which we can look at in the supplement that I've just mentioned to you. Supply chain and sustainable supply of essential medicines and technologies for NCDs can also be integrated, and we have projects also alluding to this. And the pathways, one of the projects we're doing called the Healthy Heart Africa in Kenya and now being extended to Ethiopia, also demonstrated some common care pathways with HIV. And then there are some studies also in Malawi, Kenya, and South Africa, where now we know from a policy context that there are national ART guidelines which include hypertension screening in Malawi and standard packages for care of depression, diabetes mellitus, and hypertension exist now in Kenya and in South Africa also and in Swaziland. So chronic care model, which involves the community and healthcare systems to create an informed, activated patient who is working with a prepared, proactive team to produce interactions that improve outcomes can be done for both HIV and NCD because of that common platform. So approaches the healthcare system, we have what we call horizontal blocks, which already are happening. I know there are many presentations during this time of HIV and TB. HIV and reproductive health, HIV and NCD. What we are requesting for is actually pan-horizontal integration because of the commonalities of this and the efficiencies of the healthcare system, so that the healthcare resources, including the human resources and other resources, can be consolidated in a cost-effective and sustainable manner. And then we have the diagonal approaches, the common processes that sustain health, and total integration, which we actually advocate for health not to be considered as an expense in most of these countries, but an investment in human health development, and mainstreaming health in all development agendas, so that if you look at the Sustainable Development Goals, all the 17 of them have something to do with health, because most of the drivers of health, including HIV, actually lie outside the health sector. So integrating the other sectors or mainstreaming health in the other sectors is an important way of looking at controlling health from the upstream drivers, rather than nipping on the leaves of a very big tree with very, very well entrenched roots. So most upstream drivers, as I said, lie outside the health sector, and the approach should actually be to address health of the population of a human development agenda, rather than preventing and treating diseases. So again, I allude to the supplement that we launched on Monday. Please do have a look, because we look at all these levels of healthcare system and how best to integrate. So it's a call for action, and we've reviewed some of the studies that have been done for integration at all levels, from community level to healthcare, primary healthcare level. Tried to highlight some models, identify research gaps, and also methods of research, especially implementation science research, that can be able to evaluate high-impact public health interventions to control both HIV and NCDs. Thank you.
Thank you very much. Those were really excellent presentations. I'd like to open this up for questions from the audience now to each of our speakers. We'll just take the questions one at a time. And maybe while people are thinking about their questions, I could ask you, Gerald, what do you think in this approach of integration and measurement? Clearly, PEPFAR has used indicators to guide the way that care is rolled out. What do you think should be included for indicators to measure this integration?
One of the models that have been used is to look the integration levels. So, for example, integration at a community level, and then integration at the primary healthcare level. And then when we go beyond that, there are certain health system issues that make it difficult to integrate. For example, if you're dealing with a complicated case of cancer which requires chemotherapy, radiotherapy, it's difficult to integrate that across the other NCDs and even with HIV. So the indicators that have been used for HIV actually, for example, in community behavior change communication interventions, are the same. So we look at, for example, if you use at an implementation science model of RE-AIM, it looks at reach, it looks at effectiveness, it looks at adaptability, and it looks at implementation and maintenance of that particular public health impact in that particular community. So if you look at the behaviors that we've just talked about, whether it's risky sex behavior, if you look at inappropriate diet or unhealthy diet, reduced physical activity, alcohol consumption, and tobacco, we can measure them together as indicators of the public health impact, and then see whether that particular program is cost-effective and affordable and sustainable and scalable in that particular context.
Okay.
Professor Sabin.
Thank you. Caroline Sabin, UCL. Firstly, thank you. They were fantastic talks. I really enjoyed them. Question specifically to Janine and Jean-Philippe. How much of what you're seeing, particularly around diabetes, but also cancer, do you think is actually a reflection that in many cases, people with HIV are monitored very well? So if somebody has diabetes, we actually generally know about it, whereas in the general population, you don't necessarily see that. And the same with cancer, symptoms are monitored very quickly and people are sort of directed through the healthcare system. So I just wonder, any thoughts on that? And a more general comment to everybody, do you think we've got the balance right in terms of our focus on antiretrovirals versus treatments for the microbiome, inflammation versus behavioural lifestyle interventions?
Thanks, Carolyn. I think you're right, obviously, and we would hope you're right, that individuals living with HIV are being screened more often and perhaps being diagnosed earlier, and that would be the hope. So that, the evidence probably is that we're not quite as good at screening as we should be. So, for instance, we've looked in Australia, and a huge proportion of people are still not getting a fasting BSL. So I think you're right. We're probably detecting some people earlier, but probably not as much as we need. So the rates are probably not being grossly affected by that, I think. But the hope is that you could change that, because obviously, as you know, with diabetes, if you can catch, a sort of slightly an elevated fasting glucose a little bit early by changing diet and exercise, you can actually really change the pattern of disease without needing medications.
Microphone 4.
Hi, Victoria Pillay van Wyk from the South African Medical Research Council. A comment first. In South Africa, the number of deaths due to NCDs are actually higher than those from HIV/AIDS by 2012. So we've already reached that mark. However, within the group of NCDs, we have some of them going up and some of them coming down, so there's different patterns. But then a question to the panel, how do you think people who actually have these NCDs, how is that affecting the diagnosis of HIV with the current tests available? So we know that the HbA1c is lower in people with diabetes, but that's more a management tool. But in actually picking up people with HIV when they already have a chronic disease, how do you think the tests that are available to pick HIV up are working, and is there a problem there?
Who's going to answer?
I can add. So, I don't think the presence of these illnesses is going to affect the sensitivity of the HIV screening. But as you've said, it might affect some of the sensitivity of some of the tools we use to monitor non-communicable diseases in particular, and to monitor effectiveness of therapy. I think that's where the real problem is. And then, none of us, we haven't spoken about it, but I think the other issue obviously is the polypharmacy associated with having one of these conditions. We're getting lower number of pills to treating for needing antiretrovirals, but some of these patients are ending up on huge handfuls of pills again, and so I think the management becomes much more complicated, and obviously drug interactions are a problem as well.
Front microphone, left.
Nan Presswell, GP, Melbourne. My question is to Janine Trevelyan. The incidence of diabetes in the HIV community versus the general community, I just wondered if those figures were controlled for age.
Yeah, so Nan, they were. Not all of the studies I've shown have been, but yes, they have been.
Is it surprising, because it's sort of contrary to the other data?
It is, isn't it? I agree. And I wouldn't have thought that was the case. And I looked at a lot of studies to make sure I was right before I told you that was the case. Because I agree, we see more cardiovascular disease, we see more cancer, we're seeing more of all of these other things. And may that change in the future? Possibly, but it really looks pretty consistent at the moment.
Thank you.
Microphone 4.
Hi, my name's Helen Bygrave. I work on NCDs for the MSF Action Campaign. Just a question to the colleague from Kenya. We talked a lot in this conference about differentiated service delivery, particularly around ART delivery, but also across the cascade. And we see a lot of ministries of health kind of integrating the principles of differentiated care into their national policy. Just really wondered whether there's discussions at national level how NCD care and HIV care can maybe bring together some of those principles of differentiated service delivery in terms of the management of chronic disease.
Yeah, I will specifically talk about Kenya, for example. There is the health sector plan, which clearly talks about integration between communicable and non-communicable diseases. And then we have the National AIDS Control Program, which now actually structurally includes, although this hasn't been rolled out in all the counties, but includes screening for cervical cancer, includes screening for diabetes and hypertension. And there are actually guidelines for doing that. But at implementation level is where really the problems are, and that's why we are using implementation science methods to do pilots and find the suitable models which are sustainable and scalable.
Microphone one.
Hi, Renz Lashira. Thanks for these great presentations. This is for Ken Kunisaki. I appreciate that comment. Wanted you to elaborate a little on environmental exposure that are upstream and out of the control of clinicians and people living with HIV. The example that comes to mind is in Beirut, Lebanon, where trash is burned. It actually affects waste management, and it's mostly impoverished communities that are living there that are daily under a cloud of smoke that's quite toxic and have no ability to affect that. We've heard in this meeting about crowdsourcing as a way of engaging the community positively for PrEP and for building community towards HIV prevention. And I wonder if you know of any examples where that's been done for a political solution, or at least addressing that type of problem, or it seems like it would be a meaningful idea.
Yeah, no, great. Thanks for that comment. Off the top of my head, I'm not aware of any sort of crowdsourcing approach to this. I just put up a couple examples of sort of what's happened in China and in the United States. And in China, actually, it became kind of just a complete top-down model. Right? The government just said, you need to stop doing this, and we're going to penalize. You're going to go under penalties if you do this. And so in that sort of approach, well, I don't know that that's what we want to completely advocate for across the world, that sort of governmental approach, but it worked in terms of reducing air pollution. In the United States, there's been things like the Clean Air Act, which has been a slower process, but over time has worked. And I think at the end of the day, for things like air pollution, it really, they do become political solutions. But when you bring up things like crowdsourcing, I mean, I think it's a way that, in terms of how can the public speak to their leadership to motivate, to show that people are concerned about this. One of I think our jobs in the scientific community is just to raise awareness of this. And even though people who visit these areas are kind of aware of it, in terms of solutions, I think we can do a better job of making people aware of methods to reduce this. Like you mentioned, just burning trash. That's actually, in terms of India, that's actually a big source of their pollution as well, is just burning trash in landfills. In other areas of the world, just crop burning, so burning their top layer of soil every year. That's an area, that's a source of air pollution as well. So there's air pollution at so many different levels, which can make it intimidating, but I think also there are examples of how this can be done. But it really requires political will, and a lot of that comes from individuals and then also professional organizations. So in the United States, for example, American Thoracic Society is constantly in Washington, D.C., not only pushing for better, cleaner air, but also continuing, even when these things are passed, to continue efforts to maintain that legislation, because there are efforts a lot of times to kind of chip away at what had been done in the past. So thank you. As a federal employee, I have to be a little careful. These are opinions of myself and not the U.S. government.
So Ken, I have a question. It's on the pulmonary sub-study of START. So in that study, we found reduction in non-communicable diseases, in other non-communicable diseases of patients who have been starting treatment at higher CD4. But in the pulmonary sub-study, you did not see the difference in terms of COPD. Any particular reason or any other factors which contributed to this even?
Yeah, thanks, Kumar. So, I say that, so we found no difference in the rate of lung function decline between immediate and deferred. I think we do have to be a little careful in that this was a group of patients with very early disease, recently diagnosed, all with high CD4 counts to begin with. When we look at some of the observational data out there in terms of, HIV has been identified as a risk factor for COPD, and what within HIV then additionally predicts the presence of COPD. A lot of things like low nadir CD4 count have emerged, just like they have for other non-communicable diseases as well. And I think that low nadir CD4 count, and in available studies looking at COPD, they've been nadirs like 250, 200, so really quite low. So I think, we say, I think certainly in that early group, it doesn't seem to make a difference. But I think in terms of that really low group, we don't have as much data there within START. We're doing some secondary analyses from our cohort as well, looking at what the CD4 actually was at the time of initiation and trying to understand if there's more of a signal there for particularly, I think at the end of the day, we say clearly people need to be tested and treated as soon as possible. But in those patients who are late presenters or for some other reason delay their treatment, do they remain at higher risk of COPD, and do they require additional efforts to sort of screen and look for the presence of disease? So I think we're going to try to address that question to some extent. So.
One comment, and I want to restate the other question that Carolyn asked in the beginning. There's been a lot of discussion about integrase inhibitors at this conference and the important role they play in therapy, and I think it is important in the randomized trials. There hasn't been differential dropout for this weight gain, but the other point is that people at higher risk, at least in one of the studies that you showed, were those who started with lower CD4 and higher viral load. So I think we need more information on this and among people who are starting treatment early. And also on some of the newer integrase inhibitors, there's not really been any data reported at all. And there was a period where companies weren't reporting lipid outcomes in initial studies. And I think weight is something that needs to be a part of every study report as we look at the use of these agents. And then Carolyn was asking us to comment on sort of the relative contribution of antiretroviral therapy versus lifestyle factors versus other immunologic pathogenesis or microbiome in driving these non-communicable diseases. So maybe you could, some of you could comment on her question. For your particular NCDs.
Yeah, I think obviously Carolyn knows here it is a combination of all three in nearly all of these illnesses, to varying degrees and varying combinations, and it is incredibly complex to pull that apart sometimes. Some of the studies are still just haven't been done. As Judy said, some of them we just don't have the data on, and some of them it is just that it's really tricky to sometimes pull apart what's the virus, what's the antiretroviral, what's the underlying risk factors, and all of these unmeasurable things. We're hearing about psychosocial stresses and the contribution that obviously makes. Mental health is another area that a number of these studies are not recording. A number of these trials we don't have that data as well, and that's clearly contributing. So very hard to pull apart actually how much is all of that. I think for diabetes, clearly a lot of it is lifestyle, genetics, more than the virus from the signal we've seen so far.
I'll just touch on sort of COPD lung disease, and I think, in terms of when you have a patient that is actively smoking cigarettes, and I think the focus really clearly ought to be on that as step one. I think, I've encouraged my colleagues at working in this field as well. I mean, I think really the target population among people with HIV is to look at the non-smokers with lung disease. I mean, I think that's really where the money is. If we want to understand what the virus is potentially contributing and how downstream things of inflammation, microbiome, those sort of things are affecting the lung in particular, I really think that looking at the non-smokers is where we need to be looking at. And those sort of studies, I think, are just really kind of getting off the ground. I think in terms of lung research in HIV, we've got a late start to it, so we're really early on. But I think for right now, in terms of clearly cigarette smoking is the main focus. In terms of other interventions, I think that's where the research needs to be going.
Yeah, I think there's quite a significant interaction between behavioral risk factors and between HIV and cardiovascular disease. If one looked at the earlier HIV population in East Africa, it was basically mostly truck drivers and commercial sex workers. And the distance between the port of Mombasa and, let's say, Bujumbura, which is in Burundi, is roughly 2,000, 2,500 kilometers. For 2 weeks, that truck driver is on the road. If you look at the road structure, at every stop where they sleep, it's alcohol, it's lots of roasted meat with salt, and they also smoke a lot to keep themselves awake. And when they're drunk at night and all that, and they haven't been home for quite some time, then they fall prey to commercial sex workers. So you have a cohort of high-risk cardiovascular patients entering into the HIV arena. And the treatment program for a long time did not concentrate on control of those behavioral risk factors, such that one wonders, unless we study them carefully, one wonders whether it is what contribution these traditional risk factors make to the increased prevalence of cardiovascular disease in the treated patient vis-a-vis the antiretroviral treatment. So I think we need to look at the environmental behavioral risk factors apart from the genetics and the antiretroviral treatment.
Microphone 4.
Yeah, I'd like to pick up on the discussion about the substance use and smoking versus inflammation. I think Jean-Philippe had cited data from the Danish cohort study where the impact of smoking on clinical outcomes in the setting of HIV is much greater than it is in the general population. And it's so quitting smoking if you have HIV is even more important than it is if you don't have HIV. It could just be that smokers with HIV smoke more cigarettes than smokers without HIV, but there also may be some biologic mechanisms that may increase the susceptibility to smoking-related disease in HIV, which I think is likely. And then the other comment to make in terms of the inflammation side of things also comes from Denmark, but the Copenhagen cohort, where they looked at the impact of immune activation markers, in this case soluble CD163, on mortality in both smokers and non-smokers. And the impact of inflammation was actually greater among non-smokers than it was in smokers. And so I agree with some of the earlier comments that, I think Janine may have made, that there's a mix in different patients. So in non-smokers, there really is an impact of inflammation, but in smokers, of course, the primary goal is to get them to quit.
I think probably the same might be said for obesity, that the impact of obesity on chronic disease risk could be greater in HIV than I think this sort of conspiracy between the traditional risk factors and NCDs in HIV. Did you want to make a comment?
Yes, I completely agree with you. And a couple of years ago, there is also a new study that was published and compare the risk of lung carcinoma in people living with HIV with the general population. And with statistical intervention adjusted to age, but also to tobacco, they have shown that there is still a relative risk, a high relative risk in HIV population compared with healthy people. So adjusted to tobacco, mentioning the fact that indirectly HIV can be also a cause of lung carcinoma. So I completely agree that smoking, of course, is the main cause, but not the same, but not the only one.
I think you're standing before. Microphone 1.
Sure. I want to press Dr. Trevelyan a little bit. If you have a patient now who's, say, on boosted L-bictegravir, who's otherwise not changed their activity and diet and has gained 10% of their body weight, I have such a patient, how do you manage them? They say, I want to switch their medication, maybe stop the booster. Should we get rid of the integrase class? What would you suggest doing?
Yeah, it's a great question. So the first answer is we don't have any evidence yet to tell us what is the right way or what is the best response. I always talk to my patients about it. Certainly a number of people, particularly at that point, if they're gaining 10% of body weight, that's a really significant amount. And that can be very hard to then shift just with lifestyle interventions. Incidentally, from my experience in some of the clinic. So a lot of patients, if you're in the situation where there is a valuable alternative or a viable alternative that's suitable for them, then that seems reasonable to try that. We don't have any evidence whether changing the type of integrase affects this. We don't have any evidence what degree of change in weight you get when you stop your integrase. So all of that is information we're going to need in the coming years. So I try to give my patients that sort of information, and we weigh up the risks and benefits of their current regimen versus an alternative regimen. And obviously, things like protease inhibitors, if that might be the alternative you're thinking of switching to, are not completely, innocent victims or innocents in this situation either. As we saw from the ACTG study that Judy was involved in, people who start a protease inhibitor regimen gain weight too. And protease inhibitors, some of them have quite a significant impact on lipids. So it is a real personal decision. It's no one size fits all.
Microphone 4.
Hi. So I've been looking at some of like the aging-related outcomes and NCDs in clinical data, electronic health record data, with people living with HIV, comparing them to people who are not living with HIV, trying to do age group match controls, and there's just, it seems to be, particularly when it comes to medical services utilization, what I find more in like when we compare with the non-HIV patients, it has so much more to do with literally their age. And we know that people are aging, maybe there's accelerated aging and some of these, theories about people aging with HIV. And definitely in the HIV population has to do with more NCDs and substance abuse that are the major medical service contributors. But additionally to that, so the HIV clinic that I work with, I asked one of the providers, in your population of people over 50, how many of them have HIV? And it's a racial ethnic minority, Black and Latinos living with HIV. And he said about 97% of them have diabetes. And so, that's way beyond a health disparity. So I know there's a lot of different things going on there. And ultimately, as I try to figure this out to the best of my ability and contribute to the literature, and as we understand this better, I really want to focus on interventions. So the doctor was just talking about medication interventions to support, in terms of decreasing BMI and stuff. I would just like to know any ideas, even off the top of your heads, the panel, some interventions that could potentially help with, let's say, once they have an NCD in terms of disease management. Thank you.
Yes, so there is obviously good evidence for a number of the traditional interventions that we use for non-communicable type diseases. Obviously, we know that statins are effective, and they're probably one of the most common ones that we're using, and there's big trials going on at the moment. The REPRIEVE trial to look at who or which population of people living with HIV are going to get the most benefit from a statin. As I said, I think the best money for your best buck, the best outcome for your money in weight gain and diabetes early on is those lifestyle interventions. These medications, they're in small font. They probably will work. The studies are going on, but I think if you were running a trial, if you're running a clinic, the things to think about are lifestyle type interventions, and trying to integrate the one that's going to work in your setting is probably going to give you the best outcomes. And then there are studies looking at the role of metformin in aging, in inflammation, and in diabetic prevention and control. And I think over the coming years, that's going to be really exciting too.
Sure.
I can just touch on, so for lung disease, I think, the part of it is just you don't diagnose what you're not looking for. So I think just being aware that patients presenting with the symptom of shortness of breath to also be considering whether it's heart disease or lung disease or other diseases, to be at least considering that as part of a potential diagnosis. In terms of the management, we don't have as many studies specific to patients living with HIV in terms of how their lung disease ought to be managed. I'll just make the comment that I think the one class of inhalers, mostly for COPD or even asthma, would be inhaler-based treatment. The one area to be cautious about would be the inhaled corticosteroids for two reasons, both drug interactions with the boosters, whether it's ritonavir or Cobi, so being cognizant of their interactions. And the other thing is that in the trials that have been done, for example, in patients with COPD, non-HIV COPD, there does seem to be a signal for bacterial pneumonia with the inhaled corticosteroid class, a small risk, but nevertheless a risk. And I kind of mentioned in my presentation that patients, even on effective antiretrovirals, appear to have an increased risk of pneumonia, and the addition of a corticosteroid on top of that may further increase that. Again, we don't have a lot of clinical data there, but in my general approach when my HIV clinicians refer me a patient with COPD or something like that, then I think I often am sort of using that as my last line drug. And if someone is on maximal non-inhaled steroid-based regimen and they're on a booster, then I'm working with the HIV clinician to think about, well, should we be adding that? If we do that, how do we switch their antiretrovirals to make it safe for them as well? So.
I would also like to add on the issue of stigma. The stigma associated with weight loss, which is common still in sub-Saharan Africa in patients with HIV, compels some patients to want to add weight and look at the additional weight as a measure of recovery and acceptability in the community. And that sudden increase in weight may have, I have no scientific basis on this, but I think this sudden, we know it from other non-HIV scenarios that rapid increase in weight, even when they haven't passed the level of obesity, has a much more deleterious effect than gradual or genetic increase in weight. So this rapid increase in weight, which healthcare providers also in this part of that part of the world do not seem to pay a lot of attention to, I think leads to a higher proportion of metabolic disease in this group of patients, which goes unnoticed and only gets treated when it's at the level of dysglycemia or cardiovascular disease. So stigma and associated with it, and also the healthcare providers not paying attention to these rapid changes in weight becomes a problem. So the traditional methods also still needs to be followed up. Exercise, diet, and weight control, I think, is still important, and cessation of smoking, control of alcohol consumption, which many a times patients are not counseled for adequately.
Right. So we are at the end of this session. At this time, I'd like to thank all the speakers for stick to the time. And this session very clearly shows that still lots to be studied, both in developed world and as well as resource-limited settings in the field of non-communicable diseases. And thank you so much, and enjoy the rest of the conference and have safe travels. Thank you.